So in this next video clip, we're going to look at some of the basic examination procedures for lower cervical flexion. The lower cervical spine, as you know, consists of the C2-3 motion segment all the way down to the C7-T1 motion segment. But clinically, it also includes the T1, T2, and T3 motion segments. Because in order for our patients to be able to fully flex their neck without discomfort and without a feeling of tugging and pulling and stiffness, those three upper thoracic segments have to move into flexion as well. So let's do some visual analysis. There's too many motion segments to look at all at once with your eyes. So you have to train your eyes to look at only certain areas at a time. So I'm going to have Hannah bend forward as far as she can, and my eyes are going to look here at C2, C3 first. So go ahead and bend that head forward, Hannah. Okay. We want to see that motion was recruited into C2, C3. Bring your head back up again. Now I'm going to focus on 4, 5, and 6 right in this area. So please bend that head forward again. That's where I'm looking. 4, 5, and 6. Come back up again. Now I'm going to move a little bit more behind. I'm going to look at the cervical thoracic junction. Please bend forward. And we're looking for whether or not that C7 spinous process moved upward as the vertebrae roll glided forward. Okay? And then lastly, so look right straight forward again. One final repetition, T1, T2, and T3. Please bend that head forward. And do you see the T1, 2, and 3 spinous processes move upward and drag the skin up and forward? This indicates motion recruitment into the upper thoracic region. Okay? So, we talk now just a little bit about where it makes most sense clinically for us to apply passive segmental flexion. We know that early grade disc degeneration will cause instability in multiple directions in spinal motion segments. One common direction is forward or anterior instability. We can tell whether or not that's happening at the C5 and C6 motion segment, and I mentioned those two because those are the two most common discs to degenerate, and when they do, the motion's initially going to become hypermobile. Okay? We can determine whether 5 and 6 are moving too much and too soon with a very simple passive segmental procedure. And it goes something like this. Find the bilateral lamina of C2 and then the C2-3 interspace. Here's the 3-4 interspace, the 4-5 interspace, and I'm going to go to the C5-C6 interspace. I'm going to keep my index finger right at that interspinous space, move toward our patient from the front and the side, and then make sure that I give her plenty of room, keep my elbow away from her. My left hand becomes my movement hand, and I initiate just a small amount of cervical flexion. Now in Hannah's case, she does not have any discogenic hypermobility or instability at C5 because C5 is not moving. Here's the big point. If your patient does, if there's early grade disc degeneration at C5, or now I'm going to go to C6, and you put just a small amount of motion in a forward direction into the neck, you'll feel those two vertebral segments move early and move too much. Okay? And that's an indicator of discogenic hypermobility in a forward direction. Okay? Next, we need to confirm whether or not the cervical thoracic junction, the T1, T2, and T3 motion segments contributed the way they should to flexion. So we'll push our hand down to the first rib, which is attached to T1, draw a line straight across to the C7, T1 motion segment. Now I'm going to flex just a little bit further. So keep your head and neck nice and relaxed, Hannah. And note how I bring a larger amount of passive flexion into this examination procedure, and you can see just a little bit of movement right above my index finger. What I'm feeling for is separation between the C7 and T1 spinous process. If I do, I move to T1, T2. And do I feel T1 move up on T2 into flexion? And then 2 on 3. Again, we're looking for separation at the interspinous space. sort of an upward and forward movement of the cranial spinous process on the caudal. Again, for our patients to have full cervical flexion, the cervical thoracic junction, T1, T2, and T3 at least, have to move forward. And for checking for discogenic instability at the two most common levels, 5 and 6, okay, use just a small amount of flexion and see if those two segments move right away.